All right. Today, they asked me to do altered mental status and seizure. So we're going to kind of go start with some definitions and talking about what that means. When you're looking at uh, altered mental status, we're going to start out with the definitions as they exist. The beginning of it is altered level of consciousness. Any time period where your GCS is less than 15 at any length of time, meaning it could be a period of 1 minute or it can be a period of 3 days. When you go under the altered level of consciousness, then we're talking about syncope, pre-syncope, and then we'll get to altered mental status. With syncope, these patients are the one, they have a brief loss of consciousness that completely resolves without any medical intervention. This is Grandpa sitting on the back porch. His daughter sees him through the window, leaning his head back, unresponsive, never falls out of the chair, sits back up, and she asks him, "You okay?" And he says, "I don't know what happened." And he's back to normal. He's not postictal. He had no seizure activity. Now, sometimes with syncope, it gets confusing because sometimes with a syncopal episode, people will have some tremor. So you kind of got to, dissect that out between what was just a tremor with the syncope and what was truly a seizure. If they wake up, then they're back to baseline. They have no deficits and they are not confused. Not really a postictal period, so not a seizure. So these people, the syncope, these are the guys, the vasovagal. Young guys are terrible. I don't know how many young guys in the ER pass out when you draw their blood. They're weenies. A lot of times you'll see them have what vasovagal syncope. Then you'll have micturition syncope. The old guy going to pee, passes out in the bathroom peeing. So that kind of thing. The next one is pre-syncope, early signs, symptoms of syncope nearly fading, the one that we absolutely hate. This is every old person that comes in, "I don't feel well. I think I'm going to pass out, but I haven't, but I'm weak and dizzy." The weak and dizzy involves about 26 different things, and that's what I always tell the patient. I don't know, but we'll make sure you're not going to die. So that's kind of how that goes with the pre-syncope. What we're going to get into today, the major portion of this lecture is going to be talking about altered mental status, which is under the altered level of consciousness. When you're talking about altered mental status, you're talking about something that's lasting more than just a few minutes. So a state where a patient is not alert, oriented to person, place, time, and situation within the context of expected developmental level. So when you're looking at that, if it's a kid, if it's an infant, if it's a baby, if they're under 3 or 4 years old, there's going to be some they don't know. There's a lot of things they're not going to know, but are they acting like they should? The other end of that spectrum, when you have no teeth, you end up in a diaper again. On the other end of that, with dementia, you're looking at, are they at their baseline? And that's the first thing. I look at family and I ask them, are they like they usually are? They may only know their own name. They talk a little bit. They don't do much. And that's always the big thing. Are they at their baseline or not? In the spectrum of altered mental status, you start with confusion, a little difficulty concentrating, just not quite themselves, really can't figure out what they're doing. You get into lethargy next, where they're drowsy, sluggish. They're not quite as awake and alert as they should be, but they're still in there. Getting more obtunded, you're getting into more like reduced responsiveness. You kind of have to really shake them to get them awake. Just think about somebody who's drunk and intoxicated. The next one, stupor, deep sleeping. They may only respond to painful stimuli. You pinch their fingernails, they pull it away, and then they tell you to quit it. That's kind of more your stupor. The next thing you get into is full-fledged coma, where they are completely unconscious, completely unresponsive, and not even a response to painful stimuli. So you're looking at somebody with a GCS at 3. Never, ever forget that a GCS at 3 is unresponsive, but it's also a patient who is no longer with us and dead also has a GCS at 3. Altered mental status. Altered mental status is a butt pucker to me because you do not know. It can be something very simple. It can be something very complex. And we're going to kind of cover both ends of that today. The altered mental status, as we just talked about on the last slide, is more a continuum. You're going from, kind of less responsive and then kind of going all the way to being in a coma. So it's several different things along that scale is the definition of altered mental status. The list of possible causes is literally endless. When you look through the SWONK, through the EMS protocols, when you are looking through that, there is a differential diagnosis list of 15 causes, but it also takes you to no less than 15 other protocols to fix what the differential diagnosis list might be. So altered mental status is huge. We're going to try and kind of break it down some to kind of give you an idea how to get it into the box and see what we can figure out. The objectives today is to break down altered mental status kind of in two categories, kind of stuff that you guys can fix in the back of the truck on the way, the horses and not the zebras, and the top five problems, will kind of include some other problems left that you can't fix, and I'll be lucky if I can fix, and those are the zebras that run you over. The thing is, kind of the thing for you guys in transport, you've got your finger stick, you got your glucose, you check your oxygen, you check your EKG. After that, you've worked your magic, no change, support the patient, do no harm, and get them to us. And always treat the patient, do not treat their blood pressure, and we will get into that. And that is, I should say that again, as far as I'm talking about a pressure if it's 220. I'm not talking about hypotension. I'm talking about somebody who is hypertensive. Differential diagnosis is long. Anemia, drugs, alcohol, dysrhythmias, electrolytes, head injury, hypertension, hyperglycemia, hypoxia, infection, MIs, PEs, psychiatric, seizure, shock, stroke, toxic ingestions. So I'm hoping that I don't put you people completely to sleep. And if you do, that's fine. I hope you don't. We're going to go through each one of these. And I apologize, but I didn't really know how there any other way to do this. This kind of comes under the category of saying, I want you guys to kind of know what we're looking at and what we're thinking. And when you're picking up somebody with some of these issues, first one is going to be anemia. You guys already know that. If you go to the nursing home to pick up grandma and they called you because her hemoglobin today is 6.8, so she needs transfused. On Thursday, last Thursday, it was 7.2. She didn't need transfused. The thing is you're looking at with these, and you guys already know this, it's redundant. Basically, down and dirty is every gram of hemoglobin is basically a unit of blood. So if somebody has a hemoglobin of 6, I order 2 units of blood, it should get them around 8. So it's kind of a down and dirty deal. These people can be altered just basically because I remember teaching my family this 1,000 years ago. If there's not enough boxcars to carry the oxygen, RBCs are too low, not carrying enough oxygen, makes them tired, makes them lethargic, makes them not act right or feel well. As far as anemia, the acute issues, GI bleed, if they're in a trauma, have a splenic injury, then you're getting into hemorrhagic shock and those type things. Chronic is the ones from the nursing homes or from home, and I'm talking about these people, you either have 2 issues with anemia. You're either not making enough blood, your bone marrow is giving up on you, or you're losing blood somewhere. So they have to figure out one end or the other. A lot of these poor little people, myeloplastic dysplasia and a lot of this other stuff, they just don't make blood anymore and need a couple units every couple months. Next, drugs and alcohol. Alcohol is the most common cause of altered mental status. We all know that. Do not get caught up in just drunk. We all do it. I've done it. But you got to step back if they're not waking up right or if something, use your spidey sense. If something doesn't feel right, kind of dig into it a little farther, finger stick. If they're hypotensive, if they're any trauma, just time to take a good look at them. A lot of these hospitals we're working at now, well, it's always been that way. You got your regulars. I mean, one hospital I go to, we'll end up seeing the same person drunk 4 times in 24 hours. You always just kind of want to ignore them. Yep, that's Virgil. He's drunk again. But somebody taught me this in residency 25 years ago. Every turkey has their day. So you still got to make sure you take a look at them. Assess the patient for injuries. Could still be a head injury, upper GI bleed, or trauma. They are a minefield full of badness. Drugs and alcohol, narcotics. Do they have pinpoint pupils, depressed respiratory effort? And it's always kind of a no-brainer. Well, there's needle tracks and paraphernalia laying around. Methamphetamines drive me crazy. If you look at the history in the last 10 years, here's what we've ended up with. As the United States, and I don't care one way or the other, but as the United States has legalized marijuana in so many places, drug cartels are fabulous businessmen. So what do? Can't sell pot, can't sell marijuana. I'm going to push more meth into the United States, and that's what they've done. Think about it. When was the last time you saw a house trailer burned down as a meth lab? Or the last time you saw somebody cooking meth? It doesn't happen because they don't need to. Meth is everywhere now, and we are seeing more and more of it. Agitation, confusion. If they did fentanyl, they did heroin. You give them some You give them some Narcan, they get mad because you ruined their high, and then they leave. Methamphetamines, they don't know who they are, they don't know where they're at, they don't know what's going on. You put them in the ICU for 3 days on Ativan till they finally figured out what their name is and what color their underwear was. So methamphetamines is a whole new, it's not a new ball game, but it gets pretty frustrating. Then the good old bath salts. One time I had a patient came in naked. Cops brought him in because he's running up and down his alley naked, tell him to shoot him. 5 hours later, he's like, where am I at and what am I doing? I'm like, well, you were naked. Ooh, bath salts are not good. The next one, kind of going through dysrhythmias. Dysrhythmias are going to cause you to be hypoperfused. You're not going to perfuse your brain well. Complete heart block. You know, if their rate's 20, you're not perfusing well. The other thing you got to look at, bradycardia with NMI. Remember, you're feeding that SA node off the right coronary artery, you end up with the inferior MI. You can end up with the rate problems. The other thing, overdoses, QT prolongation, and issues with that. So you can end up, it can be an issue. So that's the dysrhythmias. Dysrhythmias usually don't cause that much trouble, but when you start getting into something bad, bradycardia, severe bradycardia, and complete heart block can be an issue with the mental status. Electrolyte imbalance. I would say, as far as the electrolytes, the only electrolyte that's really going to make you altered is sodium. Everything else, potassium, you're going to be weak, you're going to have some cardiac issues, but you're not going to be altered necessarily. Or calcium, if your calcium's too low, too high, you're going to have some muscle twitching, muscle weakness, muscle issues, but you're not going to be altered. The main electrolyte imbalance that's going to cause you to be altered is sodium. Sodium, you can be anywhere from confusion to having seizures. It kind of depends on how fast this hyponatremia has happened. If it's kind of a slow burn over a month, you generally tolerate it a little bit better. If it's over 24 hours or a couple days, they tolerate that much less. For me, I'm an old hillbilly, so the best way to figure out what I'm talking about with hyponatremia, you take a gallon jug, you put, I don't know, 10 golf balls or ping pong balls in it, you fill it half full of water. Just imagine that as your sodium level. So what happens when you put more water in the gallon jug is you dilute that sodium down. That's how you end up with hyponatremia. You've got too much free water, too much water. So anything that causes that can cause hyponatremia. So if you got somebody drinking a case of beer a day, which takes a lot of time to drink it and pee it out, but alcohol abuse with beer is usually the issue. You know, these people literally are sitting and drinking a case of beer in 24 hours. They dilute everything down. The next one, I've seen a few people with this, with psychogenic polydipsia. Had a patient one time, we'd see him pretty consistent. He would get a hold of 2-liter bottles of 7-Up and he would just tear them up. He'd end up having to come in, be admitted, end up in the ICU on water restriction until his sodium came back down and his mama could take him home. So psychogenic polydipsia is an issue. The other issues are medications or anything that causes SIADH. When you're looking at SIADH, the best way to remember this one, the antidiuretic hormone works on your kidneys to keep your water in you. So if you have antidiuretic, you're not diuresing, all that free water we talked about, you're hanging on to it. So once again, you're diluting your ping pong balls, then you're ending up with hyponatremia. A lot of seizure medicines can cause that. Antidepressants can cause that. The other thing, sometimes when I see patient with hyponatremia for the first time and they're an older patient, the other things you have to worry about, do they have a cancer? Small cell lung cancers can cause an issue, so they get a chest x-ray, scan their head. So you got to look for a source for, is there a cancer somewhere causing a problem and causing the SIADH? And I apologize for this list and digging through it, but I'm trying to just kind of throw some stuff out there, why these things would cause you to have altered mental status. My God, it's a long list, and I apologize. We'll kind of keep digging through this thing here. Head injury. With head injuries, in the last 5 to 10 years, the head injury thing has become more prevalent. It used to be, hey, I almost got knocked out on a football or a soccer field, rub some dirt on it and go back. They've kind of learned that these head injuries can cause more permanent, long-lasting issues. Diffuse axonal injuries, basically shearing at the cellular level, where you still have a normal CAT scan, probably a normal MRI, but this is all at the cellular level that causes issues. So head injuries, these people are altered. We've all been on a football field helping out somewhere. That kid gets their bell rung. They may be okay initially, but then as you start talking to them, they kind of start drifting off and getting goofy. I mean, these teenage boys are goofy anyway, or a girl, or wherever they're playing soccer, whatever they're doing, but they're a little bit goofier than they usually are. So you got to look for the head injury, see what happened. The next thing is hypertension. Now, we're going to get into that later, hypertensive encephalopathy. We're talking about people that have had a consistent blood pressure greater than 200. They can have some headache, confusion, vomiting, chest pain, respiratory issues. We got to treat the patient's symptoms, not the blood pressure reading, and we'll talk about that more later. We don't want to drop out that pressure. The thing is, you still worry about with that could be having a stroke as well. But that is for us in the ER to figure out. But you guys got to treat what are their symptoms? You can't ignore the blood pressure, but we don't want to treat it. And I'll tell you more about that later. The next one is hyperglycemia can cause some altered mental status. When you're clicking their finger stick and it's too high to read, over 600, 400, depending on your monitor, sometimes those people, just because they are most likely dehydrated, you got to remember, if their glucose is that high, where the glucose goes, the water goes. So these people, polydipsy, polyuria, I mean, these people are drinking and peeing 24/7. Most of the time end up with electrolyte abnormality. They can end up with cerebral edema and some other issues from the hyperglycemia as well. Next one would be hypoglycemia. That's kind of an easy one in theory. You're looking at blood glucose less than 60, treat accordingly with D10, D25, D50, whatever you got in the back of the bus on that day. But blood sugar are less than 60. I kind of already mentioned that. A couple things about hypoglycemia. If people have had previous strokes, you'll see a lot of people that they'll recover from their strokes. They'll have some residual, let's say right side's weak. Those are the people at nighttime, they'll complain of they're tired, they don't feel well, but at nighttime, that weakness seems to get worse because they're tired. It also gets worse when they're hypoglycemic. So that is one of the things, if they're having stroke symptoms, why we want you to get a blood sugar to make sure that they are not hypoglycemic. Hypoxia, hypercapnia. These people for the hypoxia, if you're young, you're healthy, or if you're healthy, your pulse ox should be around 95, 94, 95, 96%. Hypoxia in the upper 80s can start causing some confusion, causing you not to be right. COPDers, one of my pet peeves. I've got about 5 of them. One of the pet peeves that drives me nuts is COPD. Everybody wants to throw them on a non-rebreather and make them really worse. So if it's a COPD, correct them to 90% as far as SaO2. You got to remember these people are living most of them are living to 88, 90%. And you can ask them if they can talk to you. But these are the people, COPD somewhat altered. Make sure you get that CPAP on them, get them a Duoneb, bleed some O2 in if you need to. And so spontaneous respirations, make sure that you get the BiPAP on them, because that's one of the COPD and the hypercapnia, CO2 retention, to me is always one of the more fun things to fix, because it is fixable and they do improve right in front of you. The next thing is going through pulmonary emboli. Now, these patients are going to be hypoxic, pleuritic chest pain, back pain, lots of different symptoms, just don't feel well. Now, with these PEs, the thing is, 25 years ago when I started, we didn't do a CAT scan on everybody. It was a big deal to get a CAT scan. Nowadays, it's a big deal if a patient gets out of the ER without a CAT scan. We got D-dimers, we got blood tests for PEs now. There's a lot of people in the old days, they would find a PE on autopsy, and now we find 1,000 PEs all the time. We find little PEs that probably would never cause any problems, but now all these people end up on some type of antiplatelet on Eliquis or whatever. I'm talking about with these hypoxic, these people that look like crap, you're talking about a big, large saddle block PE. So they're hypoxic, they're not doing well, they're altered. So we're talking about a clot that's sitting in one whole side of their system, in their pulmonary artery. So they are not using one whole lung. They are not getting, they're not perfusing, they're not getting diffusion out of that lung. So most of the time, if it's going to be a PE and they're altered, that's generally a big block emboli, large saddle emboli. These are the ones we end up sending interventional radiology or vascular to see if they can suck at that clot or get it thrombolized. They're going to be hypoxic. They're going to be hypotensive. You got to think about that because you're losing blood return as well because of this clot. The other thing, a lot of these people, they'll end up with an MI. They're hypoxic because of the stress of that big saddle block emboli. Their heart's working harder. Their heart's pounding against it. So they can end up with an MI as well to go along with their unfortunate big saddle block PE. The next thing, psych stuff. Psych stuff's always fine, always fun. So the psychiatric stuff, somebody's altered mental status. You got one extreme or the other. You got somebody who is severely psychotic. Is it either drug induced, like we talked about with meth? Have they been off their medications? When you show up at the house, first thing, ask family, have they been off their meds? When were they in the hospital last, and what's the deal? And have they had problems with drugs? I mean, we see a ton of these anymore with drug-induced psychosis. Those are the ones of Versed, try and slow them down if you need to slow them down so you guys don't get hurt. But is one of the things. Versed is an amazing drug, and that's one of the best things to pack in the back of the bus anymore. But you go from one end, from severe psychosis. The other end of that, you'll see some people who will be catatonic. That's pretty rare, but you still got to go through your paces with these people. They're laying there, they're not doing anything. I've seen some of these people that, not so much the catatonic, but somebody who they'll scream stroke with a normal CTA right up to the point where you're getting ready to push thrombolytics for the stroke they don't have, and then they finally decide that they're better and cured. So the psych stuff's bizarre. But anyway, you'll get some of these people that are catatonic, just kind of laying there not doing anything. I've yet to see somebody catatonic that can tolerate me squeezing their big toenail, but we'll see. Next thing, seizure. There's a lot of seizures out in the community that we never, ever get called for. Most of these people are pretty good at managing these things. Mom and dad, somebody, family member, husband, wife, whoever, that can manage these seizures at home. The easy, it was a witness seizure, didn't last any longer than usual. They're postictal at home. They're coming around. They'll either won't call or you'll get there and they seem to be doing okay. The ones that are not easy, if they've had a seizure, you get there, they're seizing again. The other thing you always have to think about, and for me that you have to think about, is a subclinical seizure. Are these people, is their brain just sitting there with this big electrical storm, but they're not visibly having any seizure activity, but their brain is seizing? So I'm old enough that unfortunately I have 52 stories of people I know with this, all the crap on these lists. My dad would do this. He had brain tumors, bleed, he had all kinds of issues. And all of a sudden he would just shut down. We'd admit him for 3 or 4 days until his brain decided to quit quivering. So subclinical seizure is tough. So that's why you got to pay attention to these people that are postdictal, extended postdictal, and they're just not waking up right. So you got to worry about subclinical seizure. Now we have the capability of doing a portable EEG in the emergency department. They can hook it up and take a look at it and see what kind of activity that we have to kind of help us sort these people out. These people are unresponsive. They end up needing intubated. Always make me nervous just because you still don't know if they're seizing and cooking their brain. So that's kind of where these bedside EEGs are really handy for that. We're talking about shock, all kinds, all the different shocks. They all basically just come down to, are they altered because their brain's not perfusing because of their blood pressure? That's what all these kind of come down to. If you got hemorrhagic shock, if they busted their spleen, if they had an ectopic, you got to pay attention to ectopics. Those are some of the sickest people I've ever seen them just instantly. Are they not perfusing because of a loss of blood, loss of pressure? Cardiogenic shock, those are tough. You're seeing more and more of these people with an LVAD or you're seeing more and more of these people with cardiogenic shock. They're keeping them going. A normal ejection fractions, 55 to 65%. These cardiogenic shock people, these people, I mean, they're keeping them alive with ejection fractions of 15%. I mean, that's just barely any kind of squish or any kind of output. So it doesn't take much for those people to fall off. The problem is you can give them some fluids, but you got to be careful with them because next thing you know, you're in, fulminant pulmonary edema, and you got a whole other set of problems. Anaphylactic shock, same thing. These people dilate out. They've dropped their pressure. They're not perfusing. So over the last few years, I think it's a great thing that we've done with these protocols, just kind of pushing epi sub-Q, trying to get epi to them a little quicker, get that pressure up and get things going. So with the shocks, you basically, each one of them, and that's kind of where you get into again with this altered mental status protocol. I mean, it clicks 15 other protocols, and it clicks the protocol for each one of these. Stroke, we're going to kind of talk to on the next slide a little more in depth. I'm sure somewhere in this series, somebody's doing CVA somewhere, but there's a few things that I wanted to throw in. Then the last thing is toxins, whatever environmental type toxins they may have gotten exposed to, whether that's drinking a glass of Roundup or whatever they've done to themselves. Stroke. So when you're talking about stroke, we're looking at, is it ischemic or an intracranial hemorrhage? Ischemic is usually 85%. Intracranial hemorrhages, 15 to 20%. So I'm telling you that just to say that the dominant stroke is usually ischemic. It's usually a clot somewhere, a piece of plaque that broke off from somewhere, and that type thing. Ischemia, how bad as far as a stroke, when you're talking about they're having an ischemic stroke, what seems to make them seem like they're altered? Well, the obvious one, number one, is they're aphasic. They can't talk to you. So that's obviously altered. They can be aphasic and have right-sided, left-sided weakness, flaccid, or not. It can just be that they are aphasic or having some speech issues. And you guys know this, there's aphasia or there's dysarthria. Dysarthria just means they can't talk, they can't put a sentence together, and those always make me nervous. But the big thing, they seem altered because of aphasic. Some of these people have neglect, and you've seen these people. You'll walk up to them, hey, how's it going? And they don't even know you're on that side of them just because they have neglect to that side of their stroke. So those people seem altered as well. They can't put a sentence together. Do they have weakness or not? But you still got to make sure that concern for stroke. The other one we're going to get into later on is a central pontine stroke in the midbrain. All of your vital signs for your body, every vital function somewhere has a tract that goes through your midbrain. If you have a central pontine stroke, whether it's a bleed, whether it's ischemia, can cause you to be, for the most part, catatonic with pinpoint pupils. It's going to resemble a narcotic overdose, but it's not. Intracranial bleeds, altered mental status. You guys have all picked them up. You guys have all rolled in. 100 times you guys have said, I think they got a bleed. Their pressure's high. They're altered. Blowing respirations look like crap. They're bleeding. 95% of the time, you're right. Yeah, you're right. That's what's going on. So altered mental status, are they herniating yet or not? You don't know until you get a scan. Sometimes you're going to be posturing. Remember, you got decerebrate, prospect, decorticate. I always remember, if it's decorticate, their arms are going to their core. So that's decorticate posturing. Decerebrate, they're extending out, not flexing. Flexing is to the core, the decorticate. These people are going to be those ones you got a blood pressure of 200, 220, which most likely, it's either that the pressure, the pressure caused the bleed or the pressure is a result of the bleed. You don't know which is who. We still don't want you to treat it. I'm going to keep hammering that, and we'll talk more about that later on to kind of give you guys an idea. I don't want you to be comfortable with it. I don't like it still, but why we do it. We're going to run through. It is 10:38. Let's run through this seizure screens. 1, 2, 3, 4. We've got 4 slides on seizure. We'll kind of hit that. Then we'll take a break, and then we'll come back and just kind of go through some cases I have to kind of look at a few other things. Good. Seizure. Seizures are interesting. They can be so many different forms, so many different issues, so many different problems. So basically, seizure by definition is a sudden burst of electrical activity in the brain. You know, the brain and heart always kind of box them sort of together. With your heart, you got a pump and you've got, you got a pump and you've got an electrical system. In the brain, you've got what the brain does, but you also got an electrical system. So if they're having a seizure, I compare it to like VFib of the heart and the brain. Everything's disorganized. You got a storm. Your brain can't do the functions it's supposed to do them because there's electricity going everywhere. So you end up with a seizure. It can cause changes in behavior, movements, feelings, and level of consciousness. I have the most respect for neurologists, especially when you get into these neurology specialty clinics at UC trying to separate out what's what. I mean, you'll have some people who have focal seizures where the behavior, they'll be acting weird, smacking their lips, doing stuff, abnormal movement of one arm, one leg. They'll just get emotional frontal lobe seizures and start crying and acting weird. You'll get temporal lobe seizures where they get angry and act weird, or you'll get all the way to the other end of it where you'll actually have generalized tonic-clonic seizure and loss of consciousness. Now, when you're talking about epilepsy, epilepsy is a seizure, but not all seizures are epilepsy, if that makes any sense. Epilepsy defined as 2 or more seizures at least 24 hours apart that do not have a known cause. So for just to tell you guys what we do in the emergency department once again. So basically, somebody comes to see us with a new onset seizure for the first time. It was whatever, it was 5-10 minutes. It lasted, they had one, they were postictal, they came around. We see them in the emergency department, we work them up, CT brain, make sure everything looks okay. And then what we'll do is we'll talk to neurology. We very rarely, I cannot remember the last time I sent a patient home with simple seizures on seizure medications for several different reasons. Number one, was it a seizure or not? Most likely. Number two, they need to follow up with the neurologist for an EEG and MRI. If I put them on seizure medicines, that EEG is going to be altered. Most of the time, people in their lifetime have a single seizure, never have another one. But what I do is we do send them home on 3 days of Ativan twice daily to depress that seizure focus, whatever it is. So if you pick up a patient and mama tells you, my son had a seizure last week, and those doctors didn't put them on any medications for seizures. That is why. First time, not medicated, follow up with neurology, get your workup, figure it out. So that's kind of the answer there. When you're talking about seizures, what causes a seizure? Remember we talked about this big burst of electrical activity? That electrical activity has to come from somewhere. There's an abnormal focus or a scar. So anything that can put a scar on your brain. I've seen people have seizures after they've had a history of stroke. That stroke, that tissue, brain tissue dies, changes. That's a focus. That's a scar. Head injuries. You'll see somebody, they were in a car wreck 15 years ago. Now they're having seizures. Same thing. They had a scar from whatever that head injury was and now developing seizures. The next one, meningitis. You have to be concerned for meningitis. It's a new onset seizure, but hey, they have a fever. So they're going to need a needle in their back to figure out what's going on there. Different types of seizures. There's a whole list. They run the gamut. Generalized tonic-clonic seizure. We all know what those look like. They're rocking and rolling, arms, legs, everything. May last 5 minutes, may last 15 minutes, stops on its own. Basically anymore. Remember the old days, stick a wallet in their mouth. Now just kind of get them on their side and let them do their thing. You worry about, did they bite their tongue or not bite their tongue? Next kind of seizure, partial or focal seizures with or without loss of awareness. Focal seizures to me are just kind of are strange. Remember we talked about an electrical storm, generalized tonic-clonic, it's the whole brain. The whole thing's just firing up. Focal seizures, if you guys remember the homunculus with the power strip down the side of your brain with the big mouth and the arms and the hands and the feet. I was going to try find it and put it in there. I forgot. But anyway, wherever that homunculus gets hit with this focal seizure is what you're going to do. So if it hits your arm part, your arm's going to fly. Your leg, face, something. So that's more of a focal type seizure. Now, sometimes people will lose consciousness. Sometimes they'll get confused. Sometimes they don't. The next one is called Jacksonian paralysis. You'll have people that have a seizure. After the seizure's done, they're weak on one side of their body. Same thing again. That seizure hits somewhere on that homunculus, on that motor strip, and that's what you've got. Unfortunately for those, we have to work them up for a stroke to make sure we're not missing a stroke. You'll talk to the stroke team. Yeah, it's probably Jacksonian, but we got to work them up. So we do. But that is one of the things with Jacksonian paralysis. After a seizure, if you lose a side, an arm or a leg, that's what's going on. You got to remember the homunculus and where did it hit on that motor strip. Febrile seizures. Nothing puts a fear of God in any of us than a baby seizing or a kid seizing. Febrile seizures, though, 6 months to 5 years of age. 5 years of age in my clinical experience and whatever it's been, generally a little old. You generally look at 2 or 3 years old for these kids. You know, is it their first one? Is it a simple seizure? Sorry, guys. Febrile seizure, you kind of split them into two areas. Simple seizure, it's one seizure. It only happened once in 24 hours, lasted less than 15 minutes. Generalized tonic-clonic resolved, they're fine now. And they check their temperature. Yeah, they got a temp of 103. With the febrile seizure, you read all kinds of different things. It seems to be how fast did this fever go up? Once these kids, parents have had it, and once a kid has had a febrile seizure, the biggest education for these parents when they leave us, make sure you control that temperature. I'll write them for a bottle of Motrin, a bottle of Tylenol, one and the other every 3 hours. In the future, watch that fever, pay attention, and keep that fever down. Complex febrile seizures are a little bit more concerning. That means that they may have had another one back to back. They may have had one an hour later. They last they last longer than 15 minutes. And it can be localized, one side, one arm, one leg. But the big thing, complex, if it's 2 in a row and it lasts longer than it should, you get into complex. Those are the ones I'll be talking to children's about and sending them to children's to see if they want to see them to work them up that day. It's not something you need to run to Children's Hospital with, but just so you know, that's kind of the difference when you're breaking down febrile seizures. The post-ictal phase. The thing is, the families or whoever's there with them is the big thing. These people are post-ictal, they're confused, they're slow. Is this lasting longer than usual? That's always a concern. Is there something else going on? That's always a concern that it may be more than just seizure if it's extended, if their post-ictal phase is not normal. Alcohol related. Here's what you get into with the alcohol related stuff. You have to tease it out. We have to tease it out between alcohol induced or alcohol withdrawal. So, some of these people shouldn't drink alcohol. You've met them. You've all got buddies shouldn't drink alcohol, but they still do. Fireball. I can't believe they sell Fireball in a bucket as party favors at weddings. That's just, stuff gives me heartburn. Anyway, just bourbon. Blanton's. I need a bottle of Blanton's, but that's a whole other story. Anyway, alcohol-induced seizure. These people shouldn't drink. There's a foci somewhere in their brain that gets aggravated when they drink alcohol, so it's an alcohol-induced seizure. These are the ones that, hey, I went out and I drank for 6 hours, I had a seizure. That is completely and totally opposite of these people with alcohol withdrawal seizures. These are these people that are binging or not binging. I've been drinking alcohol every day for 6 years. I'm drinking whiskey, I'm drinking bourbon, I'm drinking vodka. It's all the crap stuff. I always ask a patient, when they tell me they're drinking bourbon, is it good bourbon or crap bourbon? Usually crap bourbon when you buy it by the gallon jug. That's just my thing. Anyway, alcohol withdrawal seizure, you're looking at these people, they're a professional drinker. These are ones that are drinking all the time. For some reason, they decide, hey, I'm going to stop drinking today. Sometime over the next 12 hours, they can have a seizure. Now, they can still be drunk and have a seizure. If these people are living with an alcohol level of 400 or 500 and they get down to 150 to 200, they can have a seizure. They absolutely can. The other ones of these too, you got to watch. These people are alcoholics. Yep, I started vomiting yesterday. They've been vomiting for 24 hours. When you vomit, you can't keep your alcohol down. So you end up with a withdrawal seizure with those people as well. The other thing with the alcohol, you still got to worry, did they fall down and hit their head? Take a good look at them. Is that what happened? Do they have a brain injury or bleed in their head from falling down and hitting their head drunk? Most seizures are pretty self-limited. These are the ones they generally don't call you. They last 30 seconds to 2 minutes. They're post-ictal. They wake up. The true emergencies lasting, if they last longer than 5 minutes, is kind of a cutoff, 10, 15, but definitely 5 minutes. If this seizure is different than their usual, and that's the thing you got to ask these folks at the house, ask their family. The other thing too is you got to ask them, did you give them anything? Valium, Diastat, that used to be a big thing. These Valium suppositories. If you're going to be pumping Versed in them, it's kind of good to know that they already get a ton of Valium up their rectum. Injuries, tongue lacerations. I can't remember anymore what the specificity is, but if they had an altered mental status and a tongue lac, it's pretty sure they probably had a seizure. Most of these tongue lacs, they kind of get the edge of it. Most of them are pretty self-limiting, but you still got to watch that airway to make sure things aren't swollen shut. Is there any other trauma? The legendary one, I don't know that I've ever seen one. I'll probably see 6 this week. I've never seen a shoulder dislocation with an active seizure, but that's what they always teach you. So shoulder dislocation, extremity injuries. The other thing, were they driving the car when they had their seizure and ran into a head-on collision, ran into the concrete abutment? Were they standing on the edge of their roof and fell off their roof or fell off their deck or fell off a ladder having a seizure? So what else is associated with that seizure? Most of these families are calling 911. Did they have an injury with the seizure? Is it a new onset seizure? Or they generally just have focal seizure where their face twitches, they act weird, and it went into a full-blown generalized tonic-clonic deal. On the scene, what are you all going to do? Try to get some history while you're taking care of the patient as well. I know you guys are busy at the scene. You're trying to make sure the scenes are safe. You're trying to make sure the patient's taken care of. History is a huge deal. History helps. I get it. I've been doing this for a long time. Not that you guys need defended, but I defend you guys a lot when you bring people into the other individuals in the department. You know who we're all talking about. Anyway, try to get some history. Bystander history. Was it a generalized tonic-clonic seizure? How long did it last? If you want to throw in a little happy thing, I always tell them, hey, I know it seems like forever, but it was just a couple minutes. Yeah, doc, you're right. It was just a couple minutes, but it was miserable. I'm sorry. Did they have any injury with that? Where were they at when that happened? Were they on a ladder? Were they on the roof? Or were they just standing in the kitchen and went down with a seizure? Ask the family, did they have a complaint of any kind of aura? Auras are weird. Do they either smell things, see things, feel things. They know it's coming and then it hits them. Generalized tonic-clonic seizure. Have they been compliant on their medications? Did Joey forget to get his medications, his Keppra filled a week ago because he wanted to buy a new tattoo instead of his medications? So you got to figure out, where they've been non-compliant. They non-compliant on any kind of. I mean, that's the number one thing. Were they compliant, non-compliant? Is their airway stable on your exam? Tongue laceration, what's it look like? Treat extremity injuries. If the patient, Versed's a great thing. The thing with Versed, intranasal IM IV, it's great. The thing is, if this patient is still post-ictal when you get there, I would be getting a line in them because if they're post-ictal, they may fire up again and have another seizure. I just go ahead and get a line in them and get ready for some Versed IV if you need to. So if they do seize, otherwise, if they look like they're okay and they fire up another one, you can do it intranasal. It's slower. I would prefer if you guys would do the Versed IM. Just don't get hurt with them swinging and flailing. But I would prefer the Versed IM. There's a little typo in these protocols. It says Versed IM or Versed IM is preferred. The one's supposed to be intranasal, supposed to be IN instead of IM. But anyway, my preference for you guys would be the IM route, just because it's going to work faster than the intranasal stuff, preferably than on to the IV. You're doing 2 to 5 and then a max of 5 or a max of 10, and then of course their finger stick. What's their blood sugar doing? That is it for the moment. Let's take a break, and then we'll get back at it. What time we got? Why don't you guys take a 15-minute break, and then we'll get back at it. Thanks, guys.
Back on.
We on?
Yep.
Hey guys, Tony just told me that the introduction and the housekeeping slide did not get transmitted. So let's do this again. This is Dr. Emery. It's Daryl Emery. I'm an ER physician. I'm ED doc at with St. Elizabeth. You guys know me, should know me. You see me sitting in a chair somewhere. I'm working 12 days a month in emergency department, and I go to 6 hospitals. So I'm only 2 days at a certain place in a month's time. So everybody thinks I retired by the time I go back to Dearborn or somewhere else. I have not retired. I'm still around giving people crap as much as I can. I said earlier, the thing is that in honor of my first department that I had in 2000 was my first contract with Dayton Fire Department when they went from BLS to ALS. So in honor of that, today I'm wearing my Dayton Bellevue Fire Department polo, and I did not shave today in honor of all the people in Dayton and Bellevue. So just so you know that. Nothing really makes me feel old, even my kids growing up having grandbabies, but watching all these guys retire in the last 2 or 3 years that were working in EMS when I started at Fort Thomas, St. Luke's in 1998. You go down the list, you got Adam Petticord, you got Scott Kors, watched Tony forever, Tony Shaven, Josh Cox, all these guys, watching them, and then seeing these guys retire the last few years. I'm like, crap, maybe I am getting old. The thing is, though, most of you guys are young. Probably my contract in 2000 is older than most of you guys is now, but that's okay. But I see you guys coming in all the time, all these young guys with their little mustaches. I'm proud of you. I had the same mustache when I was 16 or 14. So you all just keep working on it. If you've ever got a question for me in the emergency department, stop and talk to me. If there's something you need to figure out you did well or did wrong, you stop and talk to me and we'll see what we can figure out. I don't remember names, but I remember what people do for the rest of my life. So I'm the medical director for several different departments. I'm also the medical director for Turfway Racetrack for the jockeys. I have a farm in Bratton County. I live in the middle of 250 acres, raise cattle. I have 3 quail, 2 peacocks, 12 chickens, 3 pigs, and 2 horses. So that's my life. But anyway, so this is Doc Emery. Sorry that kind of got left out in the beginning. I just want to make sure you guys didn't think I was a janitor that just sat in this chair. We're going to go over this housekeeping slide real quick, and then we're going to move on to case studies. Housekeeping. This is something I try to throw in these lectures. Just to give you, I think sometimes as medical directors and as education, and I'm not pointing fingers at anybody, but I think you guys need to be more, you guys need to know why we want you to do what we want you to do. So I think sometimes we fail at that. So these are some of my housekeeping tips, my pet peeves, whatever you want to call them. Stroke. Let's talk about stroke. Now, you guys get there, they got a stroke. The big thing with stroke is this big push to get them treated as soon as you can within 4.5 hours. That is absolutely true. But what I need to encourage you all to do is stop and get a good history as much as you can. Because sometimes, you know, they call the squad, the ambulance, you guys pick them up. Family goes to either Frisch's for breakfast, or they go to Starbucks, and they'll show up for an hour, and we don't know what's going on if this patient's facing. So we really need you guys to try and get as much history as you can at home. Most important part is last time normal. That is a critical component to this whole thing. It changes how we work them up. It changes what we do. It changes they get thrombolytics to improve their symptoms. It's a big deal. Last time normal. The thing you got to watch for, Grandma and Grandpa. Grandma says, well, we went to bed at 10 o'clock last night. It's now 7 a.m. She calls you because Grandpa can't move his left side. But the thing you got to figure out, it was at the last time normal. What I've come up with the last few years, I call the whiz time. The whiz time. All old guys get up to whiz at least once, a few times a night. I'm not that old. Me and Tony only get up to pee once a night. But a lot of these guys get up 2 or 3 times a night to take a whiz. Let's say, Grandpa, you ask, well, did he get up to go take a whiz? And Grandma says, well, yeah, about an hour ago, he went to the bathroom, he peed, he came back, got in bed, and said, scoot over, you're hogging the blanket. He was fine an hour ago. So you gotta tweak that out. You gotta work on that part, because last time normal in their head was, well, last time we went to bed at 10 o'clock. It may not have been. So try and figure out if they got up to take a whiz. Finger stick is crucial. Finger stick is important because the thing is, all these people, if they've had a previous stroke, they're hypoglycemic and make all those stroke symptoms come out. So that's why we hammer on the finger stick. I know we ask you 1,000 times, you can come in, hey, what was their finger stick? You guys always tell us, and we appreciate that, but that's why. Now, the thing with stroke, I think the biggest thing for you guys that makes you guys crazy, it would make me crazy, is where do I go? Where do I take people? Where do I show up so they don't yell at me? So the thing is, you can take stroke patients to any of our 6 facilities, and here is why. We can start the beginning of any stroke workup. What we do is a CT brain. We activate the stroke protocol, which means they're going to get a CT brain, CTA. I talk to the stroke team. We draw a bunch of labs real quick. We crank through this thing. We talk to the stroke team, let them know what's going on. We do a CT brain, regular CAT scan to make sure there's no clots or make sure there's no bleeds, no tumors. That doesn't mean anything until we get to CT angiogram. CT angiogram goes from upper chest all the way to the top of their head, and then, to look for any clots, any problems. Now, those people, if they get thrombolytics, can stay at our facilities. If those people, they figure out if they're going to get, invasive by the neurovascular team that we now have at Edgewood or at Good Sam, we will figure that out. It's not up to you guys to figure that out because I don't know. We go through 45 minutes of mental masturbation with everybody trying to figure out where they're going to go and what we're going to need to do. So you guys can go anywhere. The end of this thing, we will figure it out where they need to be if they need to have a clot sucked out somewhere. The 2 things that we've done in emergency medicine in 20 years, the biggest difference we made is stroke and CPAP. Stroke, I cannot emphasize enough. If you got somebody wiped out on the left side, aphasic, you give them the clot buster, they get better and they're walking and talking, that's huge. That means that person is not going to die in 5 years in a nursing home of a decubitus ulcer and pneumonia. So this stroke thing is huge, and I've grown to appreciate it over the years. The other thing we've done and made a big difference was CPAP. Everybody used to get nasally intubated. It's always fun to sit in the back of the squad, sitting in the squad at the racetrack, talking about the old days with the old guys when we nasally intubated everybody. I haven't seen one in forever, and that's fine with me, less blood. But if they need CPAP, put it on them, use it, get them down. Don't just crank up their O2, put the CPAP on them, get them and do them. Fractures, the next thing, fractures. What do you guys do with fractures? Hip fractures, extremity fractures. Florence is now our designated ortho hospital. But I will tell you this, if they have a hip injury, you don't know if it's fractured, dislocated, what kind of a fracture it is. You don't necessarily, if you want to take the time to do it, that's great. Take them to Florence. Otherwise, you can take them to any facility. We'll figure it out and figure out what we need to do. Sometimes at Fort Thomas and Edgewood, I'll call orthopedics. This is what I got. Some of these patients may only require a nail to drive through it instead of a complete hip replacement. Some of those they can do at the other facilities. So you guys don't have to be cracking your brains trying to figure out where should I go? Somebody's going to yell at me. What do I do? So that's kind of the story on that. The other thing, open fractures are still across the river. They need to be washed out. They need plates. They need screws. They need Elizarovs. They need some of the stuff. But if it is an open fracture, strongly consider taking it across the river. Would be my recommendation. Do what my disclaimer, do what your medical director tells you, but that's what I'd tell my guys. MIs and chest pain, recent stents, Edgewood. Obviously, MIs need to come to Edgewood for the cath lab. Basic everyday chest pain, I'll leave that up to you and your medical director. But that's kind of the deal with that. Edgewood, within the St. E system, and I'm not banging on anybody or anything else, within the St. E system, we keep doing away with duplication of services, meaning that more and more things are done at Edgewood. When you do more and more things at Edgewood, you end up with more and more squads bringing people back to get that care at Edgewood where they just left. So it's a parade of ambulances at Edgewood. So be it. Have at it. That's my disclaimer. That's my housekeeping stuff. Strokes, CPAP, strokes anywhere. Make sure you get a good history on them. All right, where are we at? We're going to jump back into where we were. 21. Case. What you got? Slideshow. Yeah, get back up.
Right there.
That one. Okay, guys, folks, we're just going to go through a few cases here, just to kind of give you some things to think about. So this first one's going to be, these are the ones I came up with 4 a.m. this morning after I drank 4 cups of coffee. So if the screen melts, that's my problem, but I think they might make sense. We'll see. So you got a 56-year-old male gets called out for intoxication, alcohol intoxication, altered mental status. You get there, patient's obtunded, mostly unresponsive, spontaneous respiration, smells like alcohol. Family tells you, well, Joey just got out of jail on Thursday and he has been drinking and partying hard all weekend long. So alcohol, you're going to pigeonhole your mind in, it must be alcohol. So you got to kind of, keep an open mind, but, start out, is it alcohol or not? Most likely alcohol. If it quacks like a duck and it looks like a duck, most likely it's a damn duck, but you never know. So you look at the patient, you do their exam, patient's unresponsive, he does have spontaneous respirations, doesn't need intubated, may need a non-rebreather, gag reflex is intact, he does withdrawal to pain, so he's somewhat appropriate there, does smell of alcohol, his pupils are 6, they're reactive, so you kind of get out of your mind, he's not constricted, so probably not anything else in there. His vitals are here, 120/62. That was, when I was an ICU nurse, that was my favorite blood pressure to put on charts. I love 120/62 was good. If they were in pain, it was 138/over 91. Anyway, guy's pulse is 48, respiratory rate's 14, pulse ox 92%. Pulse ox is a little bit low. He could use a little non-rebreather or some O's on him if you want to, and just go ahead and stick an IV in him in case something bad happens. So here's what we got. Finger sticks 91. He's drunk. You're transporting him. But on the way, he just kind of keeps going downhill, getting more obtunded, less responsive, just not doing well. You recheck his vital, his rate's 39. I'm like, let's get an EKG, keep Doc Emery happy. He's bradycardic, he has a wide complex, his QT corrected. QT corrected is 49, he's kind of widening out. Gave him some atropine, you get your fluids rolling. So, you guys, I feel bad for you. And the thing is, you guys don't get all the history we get. And people change their stories from triage, from you to triage to me. They change their stories, unfortunately. In the emergency department, we kind of get some more information. You drop him off. We roll on from there. You worry about that QTC. His girlfriend shows up. They had a big fight. So Joey decided to take a bunch of psych meds. Now he's got a prolongated QTC. So drunk's not always drunk. Use your spidey sense. Take a good look at those vitals. See what else is going on. But it's not always drunk. I get pigeonholed into the same thing at one of our hospitals, and you don't know where it is, where you see the same drunk 4 times in the same day. Everybody wants to kind of ignore them. Once again, I said it before, always remember, every turkey has their day. Dr. James Brown, Wright State, one of my guys, used to be a paramedic 1,000 years ago in Louisville. But he was every turkey has their day, so always try and keep some of this stuff in the back of your head. It's not always what it looks like. So altered mental status. We'll do another case, go through another case here. Basically, altered mental status, you got a 46-year-old male. He's got a history of bipolar disorder. He's got a history of a seizure disorder. He lives with his mama. Red flag. It happens. Things are bad. If somebody is an adult, 40 to 50 years old, and they're living with their parents in the basement, sometimes there's issues. I'm not stereotyping, but I'm just saying there might be some issues. This guy has a lot of health problems, needs his mama's help, and that's great, not a problem. But you got to think about it. Mama tells you he had a generalized tonic-clonic seizure. So you ask Mama, he has seizures all the time. What happened, Mama? She said it was different. She tells you that it lasted longer than usual. He barely regained consciousness, and he had a second seizure. He never does that. She gives him his medications daily, so he knows he's compliant. Every day she gives him his psych meds and his seizure meds, so she knows he's taking them. And this time, though, she did give him some Valium rectal just to try and get this second seizure to stop. On his exam, he has spontaneous respirations. He's somewhat responsive. He withdraws to painful stimuli. Pupils are 5 millimeters. They're not constricted. Blood pressure is 132/67, pulse is 72, respirations are 12. So everything there looks good. Vitals look okay. He is obtunded. He's postictal. So then during your exam, he has another generalized tonic seizure lasting 2 minutes. So now what do we do? Get a finger stick as usual, because that's what we want, 88. You get an IV in him. While you're trying to get the IV started, somebody slams him from Versed. His O2 sats are laid less than 95%, and throw him on some O's if you'd like. On the way to the hospital, he has another seizure en route to the hospital. So now you have maxed out on you. You may have done 5 IM. Now you did another 5 IV. You've maxed at 10. Now, let me throw this in there on this. Remember, Mama gave Billy a diastat Valium. He had Valium rectal. You've given him 10 of Versed. So maintain that airway. Keep an eye on him. Make sure he's doing okay. Hopefully not. May need a little chin lift on the way in the door. Probably not. But that's a lot of benzos. But just, keep conscious that you're pumping Versed in him after he's already had Valium rectally. So you deliver the patient and you give report. So what do you guys think? So you got a guy, he's having seizures, all that. He's had a history of seizures, just having another seizure, probably nothing, just seizures. He's having seizures. But what's one of the things we talked about? Think about the electrolyte abnormalities. What did we say? What's your major electrolyte to cause you problems? What was different this time? Compliance? No. Mama gives him every pill. She makes sure little Billy swallows every pill, gives it to him every day. Head injury? No obvious trauma. No trauma per history. He was sitting on the couch when he slumped over, had a seizure. Alcohol withdrawal. Mama watches this kid like a, whatever, and he doesn't drink. So here is the problem. Tegretol, hyponatremia. Tegretol, this poor guy, so if you're giving him Tegretol to treat his seizures, also for his psych things. Tegretol works for seizures, works for bipolar. It's a mood stabilizer. One of the problems is Tegretol can cause them to be hyponatremic because it raises their ADH levels. Remember, we talked about the ping pong balls in the gallon jug. If you're not peeing out your fluids, you're not peeing out your free water, you end up with more water in your gallon jug and your ping pong balls are diluted. So he was having prolonged seizures related to hyponatremia. Now, is there anything you were going to do for that? Were you going to give him 3% saline? No. Am I going to give him 3% saline? No. He's going to need fluid restricted. Think about that. Well, he's going to need fluid. It's always counterintuitive. I want to give him sodium. No. You're going to fluid restrict them. You got to get that water out of that gallon jug of ping pong balls, right? So he will end up being fluid restricted and treated supportively for his seizures in the meantime. Would you have done anything different? No, but it's something to think about. What are his medications and what else is going on? Next, we got a 72-year-old guy. He's got a history of COPD, diabetic, hypertension. So I don't know if I said this enough earlier. Old people and diabetics will screw you every time. If they are short of breath, diaphoretic, or anything else, make sure you get an EKG on these people because they will screw you over and have an MI and they don't know it. So 5 a.m., you're called to the house because of acute mental status. They let his granddaughter watch Grandpa overnight. That's just fantastic. So Grandpa started getting short of breath. So what's the granddaughter do? There's the oxygen. We're going to crank up the oxygen. So granddaughter kicks him up to 6 liters. And then he quit talking. I thought he was getting better. He was just sleeping. So he's obtunded, not sleeping. Exam, decreased mental status, but still minimally conversive. Here's your vitals. His pulse ox is 84 because he's not breathing much. And his blood pressure 166/89, pulse of 55, respiratory rate of 12. Sounds like CO2 retention to me. Finger stick, 168. You slap the old CPAP on him because he's still breathing and it'll do him some good. Bleed a little O2 in it, give him a Duaneb. You get him on the bedside, get him on the monitor. It's like, oh, that looks weird. That can't be right. Something's not right. You decide to do a 12 lead. You got sinus bradycardia. You got an inferior. This guy's having inferior MI on top of all these other problems. My point on this one is to make sure you don't get pigeonholed into the COPD thing and keep doing what you need to be doing. He needs a 12 lead. So you give him 4 baby aspirin if you can, chew him up, spit him under his mask, whatever you need to do. I'm just kidding. Whatever you need to do. And if you don't, we can give him a suppository of aspirin when you get him to us. Sinus Brady, but he has an inferior MI. goes to Edgewood, and roll on with your day. So here's this guy. Here's the problem. So what happened? What's the problem? First of all, he was becoming more hypoxic, and so his family turned up his oxygen, which in turn made his CO2 go up, which made him less responsive, made him more hypoxic. Think about it. And these people with COPD, you end up having an MI because you've got all these fixed lesions, right? We see them all the time. The patient will ding their troponins or heart attack enzymes. They got some lesions. They're hypoxic. They're not getting blood to their heart like they should. And next thing you know, they're having an MI. Plus, he is also a diabetic. Grandpa probably never had chest pain. Remember neuropathy. Here's the thing I always relate. Diabetics with chest pain having MIs. They can't feel their feet. They can't feel their hands. They have gastroparesis. They can't feel stuff. They can't feel anything. They can't feel when they're having a heart attack. Seriously. They'll be looking at you, no chest pain, diaphoretic, pale, look like dog crap, but no chest pain. So those people need an EKG. EKG always, never trust elderly people and diabetics. That's my spiel on that. Makes me crazy. Next, you got a 68-year-old female. She has a history of diabetes, hypertension, diabetes, MI, called out for elevated blood pressure and confusion. When you arrive at the house, I love these stories. When you arrive at the house, husband says, well, we've been in Florida, and she ran out of her blood pressure medicine about a week ago. We didn't want to bother nobody, and we didn't want to spend any extra money because we got to buy cat food. So we decided we would wait until the refill came in the mail when we got back up here in northern Kentucky. Husband tells you over the last 24 hours they've been checking her blood pressure, and my goodness, it's been high. 200 to 210 systolic. About 6 hours ago, she started getting confused and having a headache and just not acting right. Just weird. I don't know what's wrong with her. I tried to ignore her. I was reading my paper and drinking coffee, but she just wouldn't let me ignore her anymore, so I called you guys. So on her exam, she is awake, but she's disoriented. No lateralizing signs, nothing that looks like an acute stroke. She's just confused and having a headache. Not the worst headache of her life, maybe, but having a headache, not having any chest pain. So here are our vitals. She's got a blood pressure of 205 over 122. That's butt puckering. I want to treat that, but I can't because Dr. Emery won't let me. Yeah. Pulse of 88, respiration 16, pulse ox 94%. What do we do with her? What are you all going to do? Finger stick, yeah, you got to. 166, get an IV in her. You do an EKG, she's got a left bundle branch block. It's probably old, doesn't mean much, rate 82. You don't see an MI, there's no ischemic pattern. During transport, she starts vomiting, gets blurred vision. Remember, this whole thing is going to be supportive care. If you look through the protocol, supportive care only. Treat their vomiting, treat whatever symptoms they're having. And then blood pressure on recheck, 190 over 120. Hey, let me look at that other arm just to make sure that she's not dissecting aorta with a pressure that high. Both arms are okay. You reassess. She has no neurological deficit. She's still confused. She's talking. She's not aphasic. She's confused as a goose. Blurred vision, just not doing well, having a headache. Now, what do we got? This is a definition of hypertensive encephalopathy. So what is your differential for this patient, though? You've got a pressure over 200. You've got a headache. You still got to think about, is this an intracerebral hemorrhage? Is it or not? You still don't want to treat that blood pressure. I'm not going to treat that. So here's what I try to relay to you guys, you folks. I want you to know what I'm thinking when I get to the ER so you know why you're doing what you're doing for us, if that makes any sense whatsoever, and I hope that it does. When this patient hits my door, I'm not treating that 200 systolic either, okay, until I figure out what they have. If they have an intracerebral hemorrhage, yes, I'll start treating that pressure aggressively. I want to get that pressure down so that bleeding, in theory, slows down in their brain from an aneurysm or whatever, or an intracerebral hemorrhage, whatever happened. I'm going to treat that blood pressure aggressively, but I'm not doing a thing until I get that CAT scan. The other part of that could just be an ischemic CVA or something going on there. This patient, we'll talk to the stroke team just because, or I would, then they'll get a CT brain, CTA. Turns out they got a clot somewhere. I'm still not going to treat that blood pressure. You guys remember the predundrum. When you have a patient who has a clot or an emboli in their brain, they're having a stroke, that brain tissue is dying, and the outside of that brain tissue that's hypoxic, it may die too. If I start screwing with them and dropping their pressures, you're losing all perfusion. You don't want to do that. So I'm still not going to treat that pressure, even if it's ischemic. Every time I talk to the stroke team, we call it permissive hypertension. And they'll say, you can leave it at 200 if you need to, because you want to save as much brain as you can absolutely find. That's why we're not getting crazy about blood pressures in the field. The last one is hypertensive encephalopathy, which is what in this case, what I'm saying this lady had. Treat the symptoms, not the blood pressure, okay? Like we said, treat the nausea. Do what you need to do. Unless, now, if you did that EKG and she's having a big inferior MI, then you start talking about nitro in certain situations. You got to read through that too, though. You got to be careful. I had a cardiologist the other day. I had 2 MIs by 7:30 in the morning at Dearborn. Transferred them both. The second one, pressure's 200. I slapped some nitro drip on him. Well, then it's like, well, I probably wouldn't do that in case it's inferior. They may bottom out. Okay, whatever. So anyway, so the nitro, even the nitro, the aspirin, yeah, but the nitro, you got to certain situations. If it's an inferior, worry about a right-sided MI as well. The pressure is tough to ignore. I'll give you all that. I hate ignoring it. That's not what I did most of my lifetime in medicine, but we do. Permissive hypertension up to 200 on ischemic strokes. Only time to get aggressive treating the blood pressure is if they have an intracerebral hemorrhage that I talked about. Those people, we're going to try and get it down and try and get that bleeding slowed down. Hypertensive encephalopathy, just to kind of run through this again. CT brain normal, labs are normal. It's a brain dysfunction, confusion, visual disturbances, nausea, severe headache, blood pressure greater than 200, but occur at a lower level in the 180s, 170s, 160. This is one of those deals. Hypertensive encephalopathy is kind of a diagnosis of exclusion. CT, everything looks fine. Everything looks okay. This patient's still going to probably have a positive troponin that looks elevated just from the stress pounding their heart, but not an MI. But this is more of a diagnosis for us of exclusion. Everything else looked okay. This treatment formula I put in here just for one more reason to tell you guys why we don't want you to mess with it. Blood pressure 220 over 120 in the first hour, you only want to lower that maybe by 10 to 15%. We're talking baby doses of labetalol, hydralazine, apresilene. You're not getting crazy with it. You do not, and then you don't want to lower it by more than 25% over the next 24 hours. Why? Because you don't want to make them worse. Why go slow? So God made you with a system called your cerebral perfusion pressure, okay? So what happens, whatever pressure required to move sufficient amounts of blood to the brain, cerebral blood flow to maintain life and prevent brain ischemia. So what happens, your brain adjusts to this huge mean arterial pressure is your hypertension, your brain adjusts. If you start rolling in there and dropping that pressure, they were fine 10 minutes ago. Now you gave them a stroke. I've seen it happen. Of course, I didn't cause it. I would never do that, but I've seen it happen. Next thing you know, grandma can't move her right side, or she's worse. She's unresponsive because her pressure is now 120 and an hour ago it was 220. So you've got to be careful you don't want to drop these people. Dropping the pressure too fast causes problems, hyperperfusion. These old people still have some plaque, they have some stenotic areas. You're going to drop that perfusion and cause a CVA. Don't treat, let the ED figure it out. 59-year-old female found unresponsive by family. Husband tells you she was fine 3 hours ago when he left to go to the Walmart. I love the Walmart. Not really. To pick up her new oxycodone prescription. When he got back, she is unresponsive, laying on the couch where he left her. He tells you he ran out to pick up her pain. She ran out of her pain medicines 2 days ago, but thank God one of the neighbors was willing to give her 2 pain pills they think were Percocets earlier before he left to go get to the Walmart. Patient's unresponsive on the couch, sonorous respirations, pinpoint pupils. Blood pressure is there, 92 over 54, pulse 88, respirations 12, pulse ox 91%. What do? Get a finger stick because we have to. Now, pinpoint pupils unresponsive, sounds like narcotics, could be narcotics. It quacks like a duck, looks like a duck. Probably a duck, but we'll see what kind of goose comes out of the hole. So you give her some Narcan intranasal. There's no change in response, so you start giving her more Narcan. You put some extra O's on her. By the time you get to the hospital, her GCS is 3. Remember, dead or coma, GCS of 3. You get them transported, you get them there. History and exam, though, for you guys was consistent with narcotic overdose. You did what you were supposed to do. You did exactly what you needed to do. But something's not right. Didn't respond to the Narcan. Really just very unresponsive. Here, this is one of the zebras. This is zebra time, okay? And this is the kind of stuff when they get to me, is you got to be thinking about this. Grandma's not acting right. She's unresponsive. She's not doing nothing. She needs a CT, CTA. Make sure we're not missing a stroke in here somewhere. So you got a central pontine CVA. What's that mean? Central pontine. Your pontine is in your midbrain. All the functions for your vital functions, breathing, heart rate, swallowing, everything goes through your midbrain. If you stroke it with a clot or you stroke it with a bleed, you nail that system and it takes out pretty much everything. You're unresponsive and you have pinpoint pupils. So that's that deal. So we proceed through CT head, CTA head and neck, and figure out what's going on. This lady was found to have a small bleed, push it on her pons, causing problems, ends up getting intubated to the ICU, and we'll see how she does. So keep this in your back of your mind. You're pumping Narcan, nothing's happening. Doc Emery rambled about something about central pontine stroke that one time. Who knows, but we'll take them there anyway. I think this is the last one. 17-year-old male high school football player head injury. It is football time, guys. My son graduated last year. I'm kind of helping, mostly taking 40 pounds of pulled pork every Friday night to the concession stand, but I'm still around if they need me at Macon County. So when you arrive on the field, you get called for a player with a head injury during the game. When you arrive on the field, coaches describe a head-to-head collision with resulting player. He had a brief loss of consciousness. He's awake. Little Billy is slower than usual. He wasn't really ever a rock star or a neurosurgeon, but he's still kind of slower than usual. That's what's fun being on the sidelines. You figure these guys out, who's slower than they usually are slow, and then you kind of go from there. But anyway, he also has complaints of neck pain. He's still in his full gear. He's got helmets, pads, everything's there. He's laying on the ground. He is awake but slow to answer. Obvious. He has an element of concussion. He has an element of head injury. He is oriented. There's no weakness, no paresthesias, moving everything. He's on the ground. He's got midline neck pain. Vitals there. Their vitals look good. So what do we do? What do you do with these guys? So helmet on, helmet off. Here's what we're going to talk about. According to the National Federation of State High School Association helmet removal guidelines, you are more than appropriate to leave the helmet in place if the helmet fits right. You know, if it's a 12-year-old on a middle school team and his head, you know, he had to wear big-headed Billy's helmet and he's flopping around in it, make sure you immobilize his neck, get that helmet off of him. It's not going to do any good. And get a collar on him. Takes two of you to do that. We'll talk about it. If the player's got helmet and shoulder pads, he can be immobilized on a longboard, still try and attempt to get a C-collar in between there somewhere. Log roll him onto the longboard. I know we don't use longboards much anymore. This is a situation I would use one for multiple reasons, because you got to get him on the stretcher. We were somewhere 2 years ago, and my son and another kid pushed the stretcher all the way across the field to the 10-yard line after we destroyed one of the players. It might have been Gallatin County. Kid he did okay. I followed him to the ER. But anyway, you got to get him longboard. Best way to get him onto the stretcher. Just because of the C-spine thing, the helmet, I would not be standing these people up. I'd throw them on a backboard to get them on the cart. Log roll them longboard, immobilized helmet with straps. You don't need the side blocks. There's no room. Now, you have to use your spidey sense and your common sense or whatever you may have. The face guards sometimes are tough to get off. The trainer or somebody should have the tool, the Allen wrench, that you can pop that off. The reason I would recommend it in this situation, if he had a bad enough head injury, he may go down again and start puking. You got to be able to control that airway. The trainer should have the tools to remove the face mask. Now, helmet should only be removed, like we said, if it's loose, it doesn't fit right, it's not immobilizing them appropriately. If the design of the helmet, the airway cannot be controlled after removal of the face mask. For some reason, if the helmet comes around, I'm not sure what that means, but just in case. If you can't get the face mask off after a reasonable period of time, if the helmet prevents immobilization for transport in an appropriate position. These are the reasons to take off that helmet. So it's a two-person job, one to hold the neck. You guys do this stuff all the time. This is what they trained you on the first, second, and third day when you're an EMT or whatever you've done. But one to splint the neck while the second person carefully removes the helmet. Deflate pads. These helmets are getting so high tech. If they got pads inside of them or bladders, deflate those. After the removal of the helmet, the second person then maintains alignment while the first person then applies the collar. Most of these teams, we're piggly wiggly little team out in Bratton County. I'm it for the trainer. We got nothing else. It's kind of sad. I feel bad for them, but I can staple their head shut on my kitchen counter, so that works out okay for them. But anyway, most of these teams have trainers that'll pretty much help take care of this with you guys. But that's the deal with the helmets. Let's kind of review through here. Altered mental status, I will admit, is a monster. You got 15 things on the list. I could add 10 more. Be methodical. No matter what you do, be methodical. Form a habit. Do everything the same way every time. When I have a stroke patient, I come out, I tell them to put stroke pulsera, activate it, stroke team, and I do the same thing. When I do a spinal tap, a lumbar puncture, I never order the fluid orders until I have the fluid in my hand. I'm superstitious, and I do the same stuff every time. Or if I'm cooking in the kitchen, I do the same thing every time when I'm cooking. History, history, history. Just try. I know you're doing great taking care of the patient. You got to get them loaded. You got to get out of there, load and go, get out of there. But see what you can do to work on histories for CVA, seizures, some of these. And this altered mental status thing, history is going to pay dividends. That's the big thing with the history. Finger stick, exam, treat your findings. Drunk's not always drunk. Remember, chase the horses, but occasionally a zebra may run you over, guys. That'll happen. I've always wanted a zebra at my farm. I talked to here. Actually, what I want is a zonkey. Have you guys ever seen a zonkey? A zonkey looks like a zebra and it's got striped legs. A friend of mine had a male zebra and a bunch of female donkeys down in southern Kentucky. I was all excited. I thought maybe I was going to get a zonkey. He said the zebra was so mean, all the female donkeys killed him. So that's not going to happen. Those zebras will run your butt over.
That's about a woman.
Yeah, whatever. He said that, not me. So treat the symptoms, not the blood pressure. Remember that. You got a pressure of 200, 220. It'll pucker your butt, but we'll have to figure out what we got. And always remember, we are always a radio call away. You can help. Here's the 5 things you can help and you might fix before you get to us. Hypoglycemia, bradycardia, hypoperfusion, COPD, CO2 retention, slap that CPAP on, do your thing. Seizures, stop the seizure. Hypoxia, give them some oxygen. These are the ones that do your best and see what you can do. Hypertensive emergencies, alcohol and meth, hyponatremia, stroke, and psych. That is all I got, guys. Thanks for coming to let me play with y'all. If you liked it or didn't like it, I do care. You can text me to tell me what you think. 99% of you people have my phone number since 1998. Or you can just stop and harass me in the ER. I don't care. Y'all have a good day.
All right. That's what we have for today. Thank you again, Dr. Emery. I thought it was a great presentation. And as always, I do record these, and I have a YouTube channel where you can take a gander and look at any of the ones from the past. We do these monthly. The next 3 that we're going to do are all going to be pediatric. I know getting PALS has been a little bit more difficult, so I thought we would concentrate the rest of the year, October, November, and December, on pediatric emergencies. October is going to be Dr. Murray is going to do pediatric medical emergencies, and then we've got a flight nurse doing pediatric trauma in November, and a flight nurse paramedic doing pediatric respiratory, cardiac kind of stuff in December. So look for the flyers, etc., for upcoming stuff, and you can get some more CEUs if you're interested. October 9th is our conference. QR code to register for it. It's a one-day affair. We'll have some high fidelity sims. Children's Hospital is doing some simulations with us. So all around, it should be a good day. If you wanted to check out any of our past presentations, there's the QR code for the YouTube site. And we do have a website, and our newsletter, our quarterly newsletter is on there. There's articles of useful. Other than that, if you would send me a copy of the roster, just so I can have it for my records. If you want to see this, go ahead and I'll have it uploaded probably later today. And it says it's my YouTube links. I have to fix that. But anyway, I'll fix it, and all this stuff will be up, and you'll be able to get in. So thank you for your time, and you all have a good day.
Thanks, Tony. Thanks, Doc.